this is starting the CME program, and we're going to talk about injection therapy for submental fullness. Now, who knows what that is? Come on, somebody say it. Kybella, that's right, that's right. So in CME, you know, we use the name very sparingly, and we talk about the generic or whatever. Out of curiosity, how many people here have used or are using Kybella? 2, 3, 4, so maybe a half a dozen. So not very much penetration. And I would say that in my experience at the podium and in visiting offices, I've been on the road all week. I was in San Diego, I was in Phoenix. Hardly anybody is using it. And I don't know why that is. I mean, there's lots of speculation. By the way, there was an article in the Wall Street Journal yesterday that Allergan may be sold to Pfizer. So just that'd be interesting. I was a clinical investigator for the ATX 101 trials, and I am using the product in my office. And I'll try to give you some insight into what it's like, and we'll kind of walk through it. We'll discuss a little bit of the trials, the outcome, and also some patient management issues. And then if we have some time, we'll do a little bit of Q&A. So there we go. So that's my disclosure. And our objectives today are to understand the indication and the MOA of ATX 101. That's the product as it's known in the clinical trials. Provide an overview of how we developed it, and then the phase 3 trial results. So this is submental fullness, the double chin, the waddles. There's a lot of different terms that are used. And you know, previously, the treatment options have been limited to aesthetic surgical procedures, namely liposuction. I've done a lot of liposuction over a lot of years, and actually one of my favorite areas to do is the neck, because the neck technically is a pretty straightforward procedure with lipo, and the results are so nice. It's almost like it's liposuction, but as compared to other areas of the body, it's almost like a distinctly different, smaller, more minor procedure, quick recovery, great outcomes, and people are very, very satisfied. I sort of have a little joke that I've never met a woman who was happy with her inner thighs after liposuction. Always want a little bit more taken out. Whereas in the neck, people are overwhelmingly pleased. And I think the reason for that is not so much the suction. I think it's the change in the appearance. And people don't like double chins, and it's something that you sort of walk around with and everybody sees it. You can't put the girdle on, you know, you can't dress to hide things, and that, which, you know, I'm wearing black because black is slimming today. And that, so surgical procedures previously, although I think we have to mention that Cool Sculpting just recently received approval for a little mini applicator for the submentum. And so now we have, in addition for external treatment, we have an energy device. And so this was a new treatment coming out to the market for what is termed in sort of FDA parlance as an unmet need. And so it was the first-in-class injectable drug for contouring of the submental region. So this is the actual indication. Deoxycholic acid indicated for improvement in the appearance of moderate to severe convexity or fullness. That's because in the study, as you'll see, that's what we treated, was moderate to severe. And the safe and effective use of the treatment for subcutaneous fat outside the submental region has not been established and is not recommended. Now, clearly, as we all know, as soon as a product is brought to market with a label, we as practitioners can use that product anywhere we want, any way that we want, and then we assume the risk for that. And I know that this product already has been used outside of the submentum, and we will find areas to use it. However, it's my belief that you need to be cautious with this product, because this product is a lytic agent. In other words, it breaks down tissue. And as a lytic agent, if you inject it in the wrong area over the wrong structures, you can have problems. And I hope to share some of that with you so that you tread lightly in terms of using it in the right places. So I'm going to read this slide word for word. No, I'm just kidding. But this slide, this is off the label. And I think that Anytime that we have a new product to market, it is so important that we spend time to read the label. Any drug that you haven't prescribed, any procedure or product that you haven't used, the first time before you use it, I think it's really important to read the label. We have a tendency to just say, teach me how to use it and I'll go after it. And I think that it's something that it behooves us in terms of the care for our patients to really go through and understand. So there's a lot of stuff in this label. If you've been scanning it while I let that slide hang for a bit, marginal mandibular nerve injury, difficulty swallowing, injection site hematoma and bruising, tissue damage to salivary glands, lymph nodes, and muscles. So in other words, you just don't randomly pick this stuff up. And this is not just true of Kybella. This is true for all products in which we have it used. You just don't pick it up and start using it willy-nilly and hope that everything works out okay. So my advice to you is spend some time on that. I like this slide. This slide is the mechanism of action. So before treatment, we have a pocket of fat that we term to be excess, and we want to get rid of that. Well, again, we talked about you can suck it out. You can do an open lipectomy if you're in there surgically, not typically done on the neck. You can now freeze it out, and there are some other energy devices that maybe kind of reduce it a little bit. But this particular treatment, you inject it. It has a direct lipolytic adipocyte effect. In other words, it breaks down fat cells. And when it breaks them down, and that happens almost immediately. When that happens, now you have a wound, and that wound undergoes a wound healing effect. And you can see on the local tissue response part of that timeline that you have a macrophage infiltration. And then the macrophage infiltration, what they do is they differentiate into fibroblasts. And what are fibroblasts? Fibroblasts are construction workers in our tissue. Fibroblasts are what make collagen. So when you inject a biostimulatory filler, such as Radiesse or Sculptra or Bellafill, you're activating in part fibroblasts in order to make collagen. That's why we call them collagen stimulators. So you get this fibroblast recruitment, and then you have the breakdown of the fat cells, the wound healing response, and you get a reduction in volume. And interestingly enough, you don't just get saggy skin that sits there. That inflammatory response with that fibroblast deposition of neocollagenesis gives a tightening effect. And actually, it looks a lot, and in some cases, you can't tell the difference, the same as does neck liposuction. So the mechanism of action then is you kill the fat cells and you get some collagen through the inflammatory process, the skin tightens up, and it looks better. So here's an MRI showing the pre-platysmal and the post-platysmal fat with the platysma, there's sort of that nice band of muscle and fibrous tissue that's like an apron on the anterior neck, kind of holds everything in and nicely together. In some people genetically, in some people because you have maybe an ectomorphic, tall, skinny body build, or you lose a lot of weight. And also with age, we get platysmal banding. We go after that platysmal banding. If you're a surgeon, you go after it surgically. If you're a non-surgeon, you go after it typically with toxin injections and you reduce that muscle banding and can actually make a very nice effect. Women in particular don't like platysmal banding. Guys get away with a lot of stuff because it looks muscular. And I've had guys actually say, no, I like that. It looks like I do a lot of weights and strain a lot. And that I also, just incidentally, years ago I was doing lipo and I had a police officer, a woman. And when I was explaining to her neck lipo and how we can kind of do a soft liposuction and not really show the underlying architecture of the neck, and that was more feminine, I said, oh, you can take more fat out, kind of scrape it all out, and you see the underlying architecture, but most women don't like that because it makes them look a little masculine. And I'll never forget this. She kind of stands up and she does the sort of this pose, and she goes, "Hurr!" She goes, when I see a perp, I want them to be scared. Take it all out, And it's true. And so I did, and she was so happy. Because she goes, like that, and I'm like, oh my God. Okay, she scared me. I used to see her for years. She was at the airport detachment, and I travel all the time. I used to see her. I'd walk in, and I'd be going to, to security line, and I'd see her, and I wave, and she'd go, "Argh!" So anyway. So this shows pre and post treatment with an MRI, demonstrable difference in that pre-platysmal fat, that fat that is sitting outside the platysmal apron. There's also post-platysmal fat, and this is the ATX-101 treatments are not designed for that. So here's the development program, and what we're going to focus on today in that development program, you can see phase 1, 2, 3 Europe, and 3 US and Canada. There was a 3B long-term follow-up, and then a phase 4 post-approval or post-marketing study called the Contour study, which was simply a study asking patients who came in with the concern of submental fullness, whether or not they have considered liposuction. Now you would also ask about energy devices, cool sculpting, or Kybella. Try to get an idea of how they go through the decision points, and that's why they're called post-marketing studies. And here was the refined pivotal study design. So this is the study that we participated in. So you had your basic screening, and you had a 1-to-1 randomization. So you either got active or you got placebo. There was no active crossover. So, a lot of studies, if you get placebo, at some point down the road, they cross you over into an active treatment group. And it was interesting because in this particular study, there's a lot of injections, as you'll see, a lot. And you pretty much know after your first set of injections as to whether you're on active or placebo. And the thing is that you could have up to 6 treatment sessions 1 month apart. And so you, if you were a placebo patient, that's a lot of needle sticks. So what the company actually did is they promised, as part of the IRB approval, they promised all the placebo patients that if they completed the study and if the product was approved, they would get free treatments. And so that was sort of the incentive or the hook to keep them in. So we had our initial follow-up, which was 4 weeks after your last treatment. Your last treatment could be 1, 2, 3, 4, 5, or 6 treatments. And your primary endpoint was 12 weeks, so 3 months after that last treatment, whatever that last treatment number was. And again, I'll show you that. And then the end of study for you was 24 weeks after your last treatment. So that was the study design. Pretty simple, straightforward study design. We had these co-primary efficacy endpoints. And if we were to repeat the study today, knowing what I know about studies and the FDA, we probably wouldn't have these efficacy endpoints. In other words, we wouldn't have the 1-grade endpoint because the 1-grade endpoint is sort of gone away. Everything today is becoming 2-grade improvements on a 4 or a 5-point scale. And that's a harder bar to get across. So if you have mild, moderate, severe, if you're severe, you have to get to mild, and if you're moderate, you have to get to none. And that's very difficult. So anyway, in this, we had a clinician rate it, as well as a patient rate it, submental fullness rating scale. And then we had secondary endpoints. And that was the percent of patients achieving a pre-specified reduction in the submental volume as measured by MRIs. I showed you a picture of what that looks like. And then a change in baseline from the patient-reported submental fat impact scale. How many of you knew there was a submental fat impact scale? Yeah. So these are the scales that we use. I call them feel-good or psychological scales. Like I feel better about my appearance, I feel the same about my appearance, I feel worse, I feel much better, I feel really bad about it. And that helps, and the FDA likes that. Those are referred to as patient-reported outcomes. And patient-reported outcomes, especially in aesthetics, are incredibly important. The FDA requires us to do that and depends on those outcomes in the approval process. So we had both the clinician and patient scales for psychological impact, and then based on patient interviews and expert input in terms of developing those, we assess the reliability and the validity in phase 2 and in non-treatment studies. So these were people who didn't get treated, come in, they took the surveys, and then those were used in the trial. So that's how you develop that. So based on all of that, what did we get? What did we put together? Well, here is the scale. This is the validated, meaning a bunch of us sit around in a room and we score these, and we sometimes take the same pictures over again in a different order and you score them, and they look for validity in terms of your assessment, and they looked also at inter-rater correlation, meaning that if you and you and you and me do it, that we all kind of have a similar output. So we came up with the scale because, as you know, there's not a lot of scales out there. We kind of develop scales as we go along. For example, I just in the Aesthetic Surgery Journal about 6 months ago, I published a validated lip fullness scale, which was the first lip fullness scale, so for lip augmentation, that included ethnic lips. No one had ever done a scale for anything but, you know, thin Caucasian lips. So we make these scales up all the time, and we use them as an assessment tool to try to figure out how we get from point A to B to C. So you can see the definitions and you can see the fullness. And I have to tell you, when we were doing this, we're all taking the mirror and we're like, you know, I think I'm probably a 1. It's like my wife said, no, you're not a 1. I'm like, I'm gonna go on a diet, you know, anyway. So that's what the scales look like, and this is what we focused on. We focused on moderate to severe. That's why that's in the label. We didn't do extreme, and we didn't do mild, and that's pretty typical for an aesthetic study. And this is what the patient-reported rating scale looked like. So they would look in the mirror, which is not the best way to look at submental fat, you know. Maybe for guys, you know, we aren't looking a lot at like our neck and stuff. I think women spend much more time looking in the mirror because of makeup and hair and things like that. Guys just shave and hope they don't cut themselves. But when patients looked in there, they had to rate themselves. And if they didn't rate themselves in that category, then they weren't entered into the study because they had to rate themselves and we had to rate them. And then we had these other additional endpoints that I've already discussed. Like if you look at the second bullet point, you know, are you happy, bothered, self-conscious, embarrassed, looking older, or overweight? I have to tell you, everybody in this study felt like they were overweight, and that's why they had submental fat, which is not necessarily true because we all know that mom and dad give us fat pads in our body, and you can be skinny with you know, saddlebags. You can be skinny with a pooch. That's genetic, and so what's really interesting is, you know, technically and I think practically you can't spot reduce. You know, you just can't lose weight or work out and lose fat in a certain area. But now we're moving into the realm of spot reduction. And then we use that rating scale and questionnaires and all that kind of stuff. So here are the key enrollment criteria. You had to be a man or a woman between 18 and 65. You had to have a moderate or severe submental fat as assessed by those 2 scales that I shared with you. You had to have a dissatisfaction with your appearance of your submental fat. That was pretty easy. You had to have a stable body weight, and your BMI had to be less than or equal to 40. You know, that's pretty high. A BMI of 40 is pretty high, as we all know. You know, we all strive for 25 or so, and at 30 you're overweight. And no prior intervention, so you couldn't have had liposuction before. That's typically what that is. Although remember there was the lipotherapy, sort of the extemporaneously compounded lipotherapy. And there were actually some patients that came in because they had had mesotherapy, lipotherapy, and we kicked them out. And also, you couldn't have excessive skin laxity. So that was up to the evaluator, up to the investigator, as to what is excessive skin laxity. But we didn't want someone with turkey wattles hanging down because that affects the outcome. Oh yes, and also we couldn't have other causes of enlargement like goiter, you know, or other things that might be going on there. Busy slide, I won't spend much on it. This is just a comparison of the placebo group to the active treatment group in terms of age and the percent. You notice it was 85% women that came in on this, the BMI, and you can see it was very nicely matched, so your control group was matched. And here was the greater than or equal to 1 grade composite improvement from baseline. So if you look at and these are parallel studies, same study, but they're parallel studies, Refine 1 and 2. And you expect that they should be almost identical in outcome. And in fact, they were almost identical in outcome. So you saw between 66 and 70% of patients who were treated with active achieved a 1 grade or greater improvement from baseline. And here is the number of subjects experienced that in 2 to 4 treatments. So this is don't look at the brown, just look at the blue. These are the number of subjects that were treated like 1 time or 2 times or 3 times or 4 times who achieved that level of improvement. In other words, not everybody got 6 treatments. And some patients were happy, depending on how they responded, depending on their satisfaction level, and also how much fat they had. Were they moderate? Were they severe? Like that. And so to be a responder for a 2-grade improvement, and a 2-grade improvement, remember, that's like jumping, over 2 hurdles at once. It's harder to get there. So for those patients, it was lower, and we expect that. It was 13% and 18% had at least a 2-grade change. And here's the same thing. You would expect that to get a 2-grade improvement, it would require a lot more treatments. And in fact, that's what you see. The average dosage decreased with subsequent treatment sessions. And when I show you some slides on how we actually mapped and treated, I think that'll make sense. In other words, with each treatment, some of the areas in where there was less fat than in other areas, they resolved more, and in the next treatment, you didn't have to go back and treat those areas. So we had a little bit, not a lot, but a little bit of reduction in the amount that we injected. And you can see the mean injection volume started off just above 6 mLs per treatment. And you can see by the time you were out to 6 treatments, you were a little under 6 mL. So there was a little bit of reduction. And this is how the MRI imaging was done as a measurement of submental volume. There was a single mid-sagittal slice that was measured. And here is the MRI measured submental volume. So this is subjective. The mirror is subjective. How you feel about it is subjective. But objectively, you can measure that with MRI. And for those attaining a 10% or more reduction in submental volume in the placebo versus active. So 43% of the active responders, as measured on MRI, had a 10% or greater reduction. And this is that rating. This is the fat impact scale. How happy are you? How bothered are you? How much older do you look? And how much overweight do you look? That was always good for fun comments. And the subjects reported improvement in the visual and emotional impacts of chin fat. In other words, this is sort of how you perceive yourself when you look in the mirror before and then after treatment. And you can see there was a slight benefit to placebo, and there always is. But there was a greater benefit. And so you moved down on the impact scale, which means that you felt better about your appearance and you were happier. And here, again, the brown lines on the bottom are the placebo, and the blue lines on the top are the active treatment. And so you can look at this and kind of get an idea. And this is the 1 grade improvement, and this is in 2 to 4 treatments. So we can see here's treatment 2. 52% were clinical responders for a 1 grade improvement, and 71% had a clinical response after 4 treatments. So what does that mean? It means that not everybody needs 6 treatments, is what that means. And this is the subject-reported improvement of the visual and emotional impacts. And again, these are the ranges of improvement, and you can see the placebo has a little bit of improvement because patients are sort of wishful thinkers. However, when you look at these, how unhappy are you, how much older looking, in other words, there was a nice universal improvement in those metrics that we use to subjectively evaluate how you feel about your fat that was greater with active than with placebo. And you want that and hope that that's the case. And then this is the subject satisfaction with face and chin. So it's kind of the same type of thing, again, showing the placebo works. So the product was correlated with a high rate of positive subject global question responses at 12 weeks after the last treatment. So why is that important for us in practice? I mean, it's nice to look at these slides. They're very academic. They're study slides. But why is that important for us? It's important for us because when a patient comes in to buy an aesthetic treatment. If they're not satisfied, then that's an issue. Because what happens if they're not satisfied? Well, they're unhappy, they don't come back, or maybe they want, another, they want a refund, or they want more treatments for free. How many times have we, had to deal with that, right? So I think that this is really, really important to see. And I'll give you a basis of comparison. I did the original Botox phase 3 studies many, many, many moons ago. And when we did this same kind of measurement, what we got out of Botox was an 81% satisfied or very satisfied satisfaction rate. So Botox toxin treatments tend to be a benchmark, right? People love it. We say that there's no permanent side effect, and everybody responds. And you should be happy as long as you don't get like eyelid ptosis or droopy brows or asymmetry. And the other 19% that weren't satisfied or extremely satisfied, why weren't they satisfied or extremely satisfied? Well, because it hurt. Well, it's an injection, I'm sorry. Or because they expected more. So there are reasons why people will be less than completely satisfied that have nothing to do with you or the effectiveness of the product, but has to do with their expectations. And we talk about an expectation performance mismatch. I'm a car guy, a lot of you know that. If I sell you a Volkswagen, maybe I shouldn't use Volkswagen these days, but if I sell you a Volkswagen non-diesel, and I tell you that car, it drives and handles and performs exactly like a Porsche, and you go out and drive it, and you drive a Porsche, you're gonna say, I'm kind of disappointed because it doesn't. That's a mismatch. But if I tell you that car is very well engineered, has excellent handling and braking and acceleration and safety features, and you go out and you drive it and you go, yeah, I like this car. This is a good car. Now you have an expectation performance match. And what we want in aesthetic practice, and that's why this is important, we want our patients to have an expectation performance match to whatever the procedure is. Skincare, injections, energy devices, surgery, it doesn't matter. You want happy patients. So if you have treatments that don't have a very high happy quotient, then you get unhappy patients. It's bad for business, it's bad for your practice, and ultimately it's bad for the product as well. So that's why that's important. So let's take a look at some pictures of responders. So here is what we call a 1-grade composite responder. You can see the metrics here. We measured BMI. There actually was no change here, and weight was exactly the same. And we were rated both by the clinician and the patient as a moderate. And out at the exit of the study, the clinician rated this as mild, and the patient rated it as slight. That's pretty common in aesthetic. I've done hundreds of aesthetic studies, and almost always patients tend to rate their improvement or their outcome a little bit higher than the investigator, and that's just typical. So interestingly enough, this patient, who I think just had a really excellent result, was slightly satisfied. Well, yeah, some people are unhappy on Earth, right? And here, there we go. All right, so here's a 2-grade responder. I mean, that's a pretty heavy double chin, especially on the anterior view. I mean, there's a waddle there. And then you look afterwards, and there's a really nice sweep right there. That looks pretty good. I mean, I think that patient, should be really pleased. And if we look at the metrics here, BMI, essentially the same, weight essentially the same, moderate and large to absent and slight, and look at the satisfaction. And 6 treatment sessions, so that was the full Monty on the study, was 6. Extremely satisfied. And I would be extremely satisfied if that were my neck. And here's an example with the MRI showing objectively the improvement. And I'll draw your eyes to this area right here and to this area right here, okay, to make sure everybody is looking at the right place. And you see that fat pad, that submental fat pad in front of the platysma. In the platysma is the little line that you see there, and you see how much that's reduced. And look how it changes the cervical-mental angle. When we talk about, you got to pick up some anatomy terms, and I'm a dermatologist, as you all know, and I love going to plastic surgery meetings because the plastic surgeons are really, really good with their anatomical terms. And dermatologists, we tend to make a lot of stuff up. And we just invent names on things, right? So I love that. And so I'm going to share a couple of those terms that I use that actually my friend Michael Caine taught me. So we talk about when we talk about the neck and we talk about the cervical mental portion and this angle in here, we have the horizontal submental portion of neck, and we have the anterior cervical portion of neck. Remember those, write those down if they're not familiar to you, if you're not a surgeon, if you don't use those, because when I consult patients, I like to tell them yes, I use double chin and waddles and all that, but I also like to say, this is what we call this is what we call this, and our goal is to change the angle in there, because that's what, when you blunt the angle, that's the aging, the fullness, the dissatisfaction look of a double chin or a thick neck or whatever the case may be. So then let's take a look at those patients receiving fewer than 6 treatments. So there were 515 subjects in the study, and 41% received fewer than 6 treatment sessions. So figure 4 out of 10. When you looked at those who had fewer than 6 sessions, therapeutic success was 19%, so 1 out of 5. Therapeutic success meant that they reached an endpoint of satisfaction on that scale and those surveys that I showed you, and they were happy, and they decided to exit from the study prior to receiving all of the treatments that they could receive. So about 1 out of 5 were happy, in other words, with less than 6 sessions. Administrative is they didn't show up for appointments, or maybe they had other complicating medical factors, or whatever the case may be. In other words, for other reasons, they didn't show up. That was 12%. And then tolerability. So 1 out of 10 found that the discomfort level was such that they just didn't want to come back and have more treatments. So they're right, in any clinical study, subjects always have the right to discontinue that study at any time they so choose. So about 1 out of 10 did that because of adverse events and discomfort, and I'll show you those. So what are the most common adverse events in the pooled trials? So this is Refine 1 and 2. You put all the data together because they're parallel studies. And you say, okay. And what I've done is I've highlighted for you. They always say, you look in the middle of the slide, you look at the stuff that's in red, you look at where the arrow points, because that's where your eyes are supposed to go. So as we look at this, edema and swelling. So in the active treatment group, it was almost everyone, it was 87%. Edema and swelling in the placebo group was a little less than half. Now remember, the placebo group is getting needled. They're getting all the same injections, so there's a lot of needling going on. Pain, 70% found it painful, 32% found it painful. And on a degree of severity of pain, what's interesting is when you initially inject the product, it doesn't really feel any different than if you're injecting saline. But it's a lytic product, so what happens within a few minutes, so we were injecting pretty much the entire platysmal apron. And so you start here, and by the time you get to about midline, this is getting pretty hot and pretty uncomfortable. And patients like, how many more injections? How many more injections? How many more? So the severity of pain is noticeable, but we address that. If we look at numbness, so 6%, I don't know why a placebo would have numbness, but then people sometimes imagine things. But if we look at numbness, 66% of the patients had numbness afterwards. It's a dullness is what I would say, rather than a true anesthesia. It's a dullness and a feeling like it's kind of asleep, like when you cross your leg and your foot falls asleep and you tap it. Kids are always kind of amazed by that. They start like taking pins and stuff and poking their foot to see if they can feel it. It was described, at least to me, like that. If we look at induration, so induration, now remember that there is a fibroblast effect. Macrophages come in, they differentiate into fibroblasts. The fibroblasts are in that inflammatory milieu that's a wound healing milieu, and they're making collagen. So sometimes induration is a good thing, right? We want induration for some things because it tightens tissue and it gives a better overall result. So induration was definitely present. Paresthesias, most commonly formications, okay? And I didn't say fornication. I said formication with an M. Formication is the sensation on your skin of like insects walking or crawling. You've all had the ant coming up the back of the leg and you do that, or you feel like a mosquito land on you. That's a formication if there's no bug there. There were no bugs here. But the patients talked about paresthesias, and the paresthesias were most commonly reported as a sensation of a tingling or like an ant walking or crawling on the skin. So it's more of a nuisance than anything else. Nodules. So we had nodules, and the nodules are part of the inflammatory effect, and they go away. And itching was present as well. So itching and paresthesias and the numbness are all kind of different sides of the same coin. So that's kind of what they're going to feel. Now, here we have the incidence and severity of pain, and it declined after the first treatment session. So here in the first treatment session, just look at the blue, because this is needling pain here. And yes, people get used to needles for the placebo. But we had some severe, but most of it was moderate and mild. And there is a reduction. I think you get used to it. I think we were using a little less product. We were injecting a little smaller area. And so there is that discomfort. Edema and swelling, and same thing. But part of that is the expected treatment result. Hematoma. Now, hematoma is a needling effect. And you're going into the neck, and the platysma is right there, and it's just like when you inject toxin into platysmal bands. I'll come to questions at the end. When you inject toxin into the platysmal band, you sometimes get these little hematomas in the muscle. So that's what that was. Here's the median duration of adverse events. So this is the average. So for the numbness, 40 days. For the induration, 28 days. For nodules, 22 days. So you can kind of take a look at that. So now what I want to do is, now I've given you an idea of what it is and how it works, how we measured it, how we conducted the study, and what they look like, sort of what you do when you actually go and do the treatment. Well, you do your assessment and you select the appropriate patient. You set the expectations. That's really important with this product. Really, really important. That's that expectation performance match or mismatch. The old adage about, excuse me, about always, under promise and over deliver in medicine is true here as well. You clean the area, you identify the external landmarks, you mark the treatment, you apply the injection grid, and you determine the dosing, and then you inject, and then you administer post-injection patient management, including the assessment of swallowing and swelling, and then have your office follow up. So here is an example of the boundaries that we are looking at. One of the things you don't want to do is you don't want to inject nerves with this. And you have the marginal mandibular branch of the facial nerve that comes right across the jaw. A danger zone in surgery and a danger zone in liposuction. So if you're injecting over that nerve, nerves, of course, have a myelin sheath, which is lipid rich. This breaks down fat. So if you're injecting over a nerve, what's going to happen is you're going to break down that myelin sheath. As you break down the myelin sheath, you're going to get the dysesthesias and that type of thing. So you have to map the area. And then you have the submental crease, and then you have the hyoid bone, which is your inferior boundary. And you mark it. You mark the sternocleidomastoid, the thyroid notch, and the inferior mandibular border. And the submental crease, the hyoid bone, and the lateral borders. So what you're doing is you're mapping your treatment area. Really not all that different than liposuction. And then you mark a no treatment zone to avoid marginal mandibular nerve injury. And in fact, when I do neck lipo, I kind of take one of my markers and I put an X right there, because when the neck is all inflated with the tumescent anesthesia, you can kind of lose track of that. It's also a nice visual reminder. And this is what it looks like if someone has a marginal mandibular nerve injury. They present with an asymmetric smile, because what happens, the depressor anguli oris is knocked out, so that side doesn't pull down. And so here is a nice summary of the treatment area markings. And as you can see, the sort of the brown area, this is your treatment area. Now, this is distinctly different than what we did in the clinical trials. And this is all for patient safety. In other words, in the clinical trials, remember, I said we were injecting essentially the entire platysmal apron, and up to 6 treatments, up to 10 vials. Well, we've learned, and that's why you do trials, you've learned how to do it a better way. So don't be a hero with this stuff. Don't try to do the whole anterior neck. Look for that appropriate fat pad right there, and have them swallow, assess, feel the neck, feel the thyroid, things like that, and make sure that it's fat that you're dealing with, and that there's adequate fat, and that you are adequately away from the no treatment zone. And then you can do your pre-treatment patient comfort management. So you can use high-dose NSAIDs, a single dose usually, topical anesthetics, injectable anesthetics, ice or cold pack. I'm an injected lidocaine kind of guy for this, although a lot of offices use ice packs and seem to do well with that. I guess it depends on how tough your patients are. And then you apply, it comes with this injection grid. It's like a little tattoo. You moisten it, you put it on the skin, you pull it off, and as you can see in the bottom panel, you've got all these little injection grids, all these little points. What that does is that puts you at the right distance between injections. And then what I like to do after I apply that, I'll customize it first to the patient as to how much I put on in the tattooing. And then afterwards, what I do is I wipe away the areas I'm not going to inject. So typically, you'll wind up from anywhere from 16 to 20 to 24 to 28 or 30 injection points, and that's the actual injection. Your setup is pretty easy. Doesn't look a lot different than your setup for toxin or filler. And that's just your little inventory list there. So this is what it looks like, and this is what I'm talking about. See, I would wipe away some of those and some of those and those there. I would wipe away anything outside my marked treatment area. Those, I just wipe those away. Then this comes pre-mixed, and a single injection consists of 0.2 mLs spaced 1 centimeter apart, and you can do up to 6 treatment sessions at intervals of no less than 1 month apart. Now, if you want to go longer than that, if you want to go 6 or 8 weeks, that's fine. Or you want to go 3 months, that's fine. But you don't do it closer than a month. And that's that inflammatory wound healing process, the neocollagenesis, the tightening of the skin. You don't want to treat too close together. So I like to pinch up just a little bit, and I take that needle and I go in perpendicular with the skin. I just go right in and I inject 0.2 mLs. Now, sometimes as you get out around the edges, you may not want to do a 0.2 ml injection. Maybe there's less fat there. You're going to kind of feather it out and taper it off. You might do 0.1 or even 0.05. So I don't recommend doing more than 0.2 mLs at one time in an area, because I think that it's better to go ahead and just do another treatment session than to try to slam more product in at once. And then you repeat as necessary. It's very important that you communicate your post-treatment out-of-office care. The bruising, the pain, the numbness, the swelling, the redness, the tingling, all of those sorts of things. And this goes on for a while. So this isn't like you're doing some toxin or filler and they're going to have a little bruise or some discomfort for a few days. I mean, as you saw, this can go on for weeks on end. So you have to tell them there's a process. I always tell them it's the healing process. It's the medicine working. And they should use cold packs, compression, or oral analgesics to reduce common side effects. That's the pain and the tingling. And call if they have questions. And then the patient comes back in the subsequent sessions. You evaluate them. So, this is a little bit like Sculptra, right? Treat, wait, assess. Do another treatment, wait, assess. It's that same concept. So, unlike liposuction, which is generally a one-time event, this is a multiple-time event. And you may go up to 6 treatment sessions. So, in summary then, in the trials, statistically significant reductions in submental fat, good improvements in the visual and emotional impacts. Most of the subjects experience a clinically meaningful improvement in 2 to 4 treatments. That doesn't mean that someone might do okay with 1 or someone might need 5 or 6, but that just kind of gives you that idea. And most of the adverse events were mild or moderate, and they decreased in incidence and severity over successive treatments. So that's the presentation. What I'd like to do, I can take 1 or 2 questions. We're a few minutes behind, and in respect to the other speakers and the program agenda, I want to keep on time. But there was a question there. Yes, sir? When they say hematoma, is that a frank surgical hematoma, or are you just seeing ankylosing? So the question is, When it says hematoma, is that like a frank surgical hematoma, or is it more ecchymosis? You know, it's small. What it is, to me, it's identical to what you get when you're injecting platysmal bands with toxin. And you get those little nodules that I believe represent a hematoma within the muscle banding. And none of them required any type of surgical evacuation, if that's what you're referring to, and they resolve. So I'll do another question if there's another question. Yes, sir.
Long-term neurologic deficits.
Ah, that's a great question. So all of the patients who had marginal mandibular nerve branch injury, they all resolved. It can take a while. It can take some months for some. I think that we were being kind of aggressive in the study. And I think with the mapping that I showed you, if you do it that way, that the risk of that is significantly reduced and ultimately resolves. You remyelinate the nerve. So you're not transecting the nerve. You're just reducing the myelination. So it's a nerve injury. And so, all right. And, you know, I'll be around. I'm around all weekend, and I'll be happy to answer other questions. And what I hope that you all do, since the vast majority of you here are not using Kybella, I hope that this gives you some baseline information, and you can think about how that might fit into your aesthetic practice, how you might be able to use it. And I'll tell you, for the non-surgeons who don't do liposuction, this is another body part that we get to treat, right? It's like kind of like radius and hands, and you know, you got Kybella and double chin. We look for body parts because that expands out our armamentarium of therapies.